Okay.
Hello, everyone. My name is Dr. Azevedo, and today I'm going to tell you about Huntington's disease. I will start with a brief introduction. I will talk about the symptoms, show some videos, talk about the pathogenesis, the diagnosis, and then the management. So Huntington's disease is a hereditary autosomal dominant neurodegenerative disorder, and it affects about 1 in 10,000 people, which is very common for a rare disorder. In fact, it affects about 40,000 people in the USA, and a lot more people are at risk. So it's caused by a mutation in the HTT gene in exon 1, and it's a special type of mutation. It's a trinucleotide repeat mutation. So in this portion of exon 1, there is a repetition of CAG, 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 and usually the number of repeats is below 26, but in some people it is above 36, and there is a reduced penetrance. So there is a chance that the person will develop Huntington's disease. And so, for some people, the number of repeats is above 40, and it is certain that they will develop the disease. In fact, for some people who have over 60 repeats, they will develop the disease a lot sooner and will have juvenile HT, which starts below the age of 20. And it's interesting how this mutation is very unstable. So from one generation to the other, the number of repeats can increase, especially when the disease is passed on by the father, because the number of repeats can expand during spermatogenesis. There's also somatic instability within each tissue. So throughout our life, the mutation can increase, namely in the striatum, which you can see in this picture is really affected in HT. What symptoms do HT patients have? They have not only motor, but also cognitive and behavior symptoms. There is a pre-symptomatic phase in which there are no symptoms, then a prodromal phase before the motor diagnosis in which there are already some symptoms, and then the symptoms evolve such that it starts with chorea, and then it develops into a more hypokinetic and phenotype. There are always motor, cognitive, and behavioral symptoms. Usually the age of onset is around 45, but as I mentioned, this varies. So 5 to 10% of the patients will have juvenile HT below the age of 20, and some will have it after the age of 60. Okay, so a little bit more about the symptoms. So in terms of motor symptoms, there is chorea, which consists of involuntary, brief, irregular movements that are not repetitive or rhythmic and appear to flow from one muscle group to the next. We'll see videos which will help understand. It can also affect phonation, so the speech, and it is usually present at rest, but it disappears during the sleep. And it can be intensified when the person is distracted, and the patients usually are not aware of the movements in the beginning, but as the disease progresses, they might start incorporating the Craig dance-like movements into semi-intentional movements. Okay, but besides chorea, as I mentioned, later on we get different symptoms, such as bradykinesia, so more difficulty with voluntary movements, and dystonia, imbalance, and other symptoms. So still in terms of chorea, if it is more pronounced, and particularly in the proximal muscles, we can have balismus, which are dance-like movements, but with greater amplitude and speed, which can be very harmful for the patients and lead to traumatic lesions. And there can also be atetosis, which is a slower dance-like movement with a twisting nature. So dystonia is a bit different. It's also involuntary, and it's associated with prolonged muscle contractions, sometimes agonist and antagonist muscles at the same time, and it causes repetitive and twisting movements and postures. Other motor symptoms are, or findings are changes in the eye saccades and also motor impersistence. So the patients can keep the same movements for a period of time. For instance, a hand grip would be very gentle. There is even a term, a milkmaid's grip for the grip of an HD patient. Okay, but it's not all motor. There are also cognitive issues, namely in terms of working memory, poor planning, inflexibility, perseveration, impulsivity, and also behavioral symptoms. Of the behavioral symptoms, apathy, lack of initiative is very pronounced, and it's present in almost 1/3 of patients, and it progresses with the disease, which is different from the other symptoms such as irritability, depression, and anxiety, and OCD, which are less frequent. Psychosis is relatively rare in this disease. Then there is juvenile onset HD, which is interestingly a bit different. So there's a lot more rigidity and bradykinesia, tremor, dystonia, and it progresses a lot faster. And chorea might be very transient. Okay, but let's now look a bit at what the patients look like. Okay, trying to find, just 1 second. Okay, can you see it?
Yeah.
So you'll notice this lady, the movements are completely involuntary. Some of them seem semi-intentional, but it's definitely chorea, a dance-like movement. And it's interesting that she actually didn't appear to have parents with HD, but because she was adopted, she didn't know them. Okay, I can also show you a different patients. You can see that the phonation is also a bit affected, and there is retropulsion. And then I would also like to show you a different patient, now a pediatric patient, and you'll see how different it is. So you'll notice the dystonia in the hands and the slight choreic movements, but mostly the dystonia. Okay, and then I would also like to show you to show you something that looks a lot that looks more like balismus. So you see how the movements are a lot more pronounced and proximal. Okay, and then just an interesting part of the presentation. So notice how the eye movements are affected. He needs to actually move the heads to follow the finger. Okay. Okay. So notice now the motor impersistence. He just can't keep the movements. Yeah. So the patient really struggles with this type of motor tasks. Okay, so back to the presentation. We've seen different types of patients, and it's important to understand how this disease affects their life. So for most patients, they will know from an early age an affected parent, and they will be aware of their at-risk status. And so this is something they have to live with until they reach the age of 18, after which they can decide whether or not they want to know if they are going to develop the disorder through predictive genetic testing. And this is something that few people actually go through because it's a very hard life decision. There still isn't a disease-modifying treatment, and so only about 7% of patients actually go through. And it's also important to know that there is a real risk with taking this test, because some patients may have difficulty coping with the results and may even commit suicide. So it's really important that this type of information always be prepared, so that the patient understands exactly what type of information he will receive, and he can make a decision of whether or not he wants to receive it, and that he receives it in the best possible way and with the best psychological support possible. And so that's predictive pre-symptomatic testing. That's something very different from what happens if the patient already has symptoms. In that case, we really want to make sure whether it's HD or something else to be able to give the best treatment possible. So that's diagnostic testing. And for instance, with this young lady, it would make sense to test her for HD because she has a family history and she has symptoms. So it's important to know whether it's really HD to help her. Okay, so now I will try to make a summary of the research in these fields for the last 30 years. Okay, this is a lot. I tried to make it as simple as possible. Okay, so we definitely know that there is a mutation which has a number of CAGs that is above 40. And this mutation is unstable. And it's particularly unstable if it is just CAGs uninterrupted. If there is, for instance, a CAA, which also codes for glutamine, it will interrupt the chain of CAGs, and that way it will make the repeats more stable, and the disease will happen later in life. Okay, but so what happens when you have a long CAG repeat without any interruptions? You get abnormal DNA secondary structures, and these DNA secondary structures can interact with DNA repair machinery and DNA handling machinery. And that interaction leads to somatic and germline expansion. So when this type of machinery contacts with the CAG repeats, it leads to expansion of the repeats within the cells of, for instance, the striatum. And the number of repeats keeps on growing. And so when the number of repeats goes above a certain threshold, we have the start of pathology. So there are genetic modifiers in the DNA repair machinery that leads to an earlier or later age of onset. Okay, but that's how the pathology starts. How does it then translate to neuron dysfunction? So if you have a high CAG number, that will lead to changes in splicing. So instead of having the whole protein, you'll start having more of just the small transcript with exon 1, which seems to be more toxic. or you can have the regular mutant protein and have it then broken down into the shorter form. What happens then is that the mutant HTT will aggregate both in the cytoplasm and in the nucleus, and it will impair lots of things in the cell. So it will impair the transport between the nucleus and the cytoplasm. It will impair proteostasis, axonal transport, transcription, translation, the mitochondria, synaptic function, a lot of things. There are also new mechanisms such as transcription of the repeat itself. So transcription starting on the repeats, which is very different from what we're used to. But everything is still being discovered. So there's a lot of unknowns about how the pathology leads to neuron dysfunction, but there are already many findings that could all happen at the same time. So once we get neuron dysfunction, how does that lead to symptoms? Okay, so as I mentioned, the CAG expands particularly in some tissues, namely in medium spiny neurons of the striatum. And it starts with the indirect pathway. And when this pathway is impaired, then you get an hyperkinetic phase with preeminent chorea. Then there is a prion-like spread, and the direct pathway is also affected. And then we get an hypokinetic phase with bradykinesia and dystonia. And then it also spreads to other parts of the brain, leading to the other symptoms that we mentioned. So just to give you a picture, you see here how in early HT, we have an impairment of the indirect pathway, and that leads to a hyperkinetic output, while in late HT, when both pathways are affected, the output is a bit different. It's hypokinetic. And it's interesting to understand that the basal ganglia are involved in a lot more than just movement. So they're also involved in limbic circuits and cognitive circuits, which could help explain how there are symptoms also in terms of cognition and behavior. So how do we actually diagnose HT? So we need a family history or a positive genetic test, and then we need onset of motor disturbance. And the way it's defined is through the unified HT rating scale. So you need a total motor score of 4 or more. And this is something that you calculate looking at all these features, which are all scored from 1 to 4. So 1 being very little change, and 4 very strong change that leads us to think of HT. So we have ocular pursuit, saccades, dysarthria, tongue protrusion, dystonia, chorea, retropulsion, finger taps, pronation, supination of hands, luria. I don't know if you know this, but luria is, so it's a sequence of movements. It's fist, hand, palm. I don't think you're seeing my, seeing me, but so it's a specific sequence. And so it gives more information about the cortex. So being able to program a sequence of movements, and it's a bit different from dysdiadochokinesia, which is more cerebellar, which is involved in rapid alternating movements. Okay, and also rigidity of the arms, bradykinesia, gaits, which can become widened, and tandem walking. So lots of features which we can then monitor to assess progression of the disorder, but in order to consider motor onset, it has to be 4 or more. Okay, and if you only have family history, then it's definitely interesting to also get an MRI or a CT to look for caudate atrophy and to to have some consistency, and also to check for the thyroids and for Wilson, so looking at copper and ceruloplasmin, because you want to make sure that it's not a different type of chorea. And as I mentioned, there is a pre-manifest stage in which before the motor onset, which can happen 10 to 15 years before this onset. Okay, and you can monitor other things to get a fuller picture in terms of cognition, in terms of behavior, for instance, moods, anxiety, suicidal thoughts, which can be very, very prevalent when the symptoms start, irritability, OCD, and hallucinations, even though they are relatively, they are not so frequent. So one interesting test is the Stroop interference test, which tests the ability to inhibit cognitive interference. And after the motor onset, this is something that's really changes, and that allows us to monitor the progression. So you can see how it's more difficult when you have blue and you have to say the color is green. So there's an interference. Okay, and there's also a assessment of the functional status, the independence, and the functional capacity. And this is important because you can predict what kind of care the patient will need. And you can be ahead of things so that you can provide the best care possible. Okay, and there have been a lot of observational clinical trials. So now we know that in terms of the MRI, we can see before the functional changes in brain atrophy, in particular of the caudates and white matter. We can also start seeing some pre-manifest changes when we look at patients 2 years after, namely in the motor score, emotion recognition, and speed tapping. Okay, and there are new quantitative assessments that can help us keep a better monitoring of the patient, especially for trials. Okay, so is it just HD? In 7% of patients, there is a HD phenocopy. So you don't have the HD mutation, but you have chorea, cognitive, and neuropsychiatric disturbances. And so for these cases, only in a small portion can you identify the cause. It could be C9orf, it could be a spinocerebellar ataxia, or HD like syndrome 2, especially in people with from African population. You should also be aware of other symptoms such as ataxia and peripheral neuropathy, which could suggest spinocerebellar ataxia or fiducious ataxia, seizures, which could suggest dentatorubral pallidoluysian atrophy, and you could also look at iron in the MRI because of iron accumulation disorders, and look at the peripheral blood for acanthocytes, so misshaped erythrocytes, which are suggestive of neuroacanthocytosis. And you can also look at causes of chorea in general, and so you'll get a lot of things that could cause it. So chorea is different from having motor and cognitive and behavioral, so which is more like HD. So for chorea, anything that affects the striatum, be it vascular, tumoral, or brain injury, could be at the source of it. There is also chorea associated with pregnancy, and also with lupus, thyroid problems, and post-infectious syndromes. So about 20% of people with rheumatoid fever can develop chorea. There are also other things that can lead to chorea, such as drugs, neurometabolic conditions such as Wilson, and even a deficiency of vitamin B12 in some case reports, and other toxic vascular and hereditary conditions. And if you want to look at chorea, there is a lot that you can explore. But what's really important is the history, when it starts, whether there is a family history, whether it's static or if it progresses, whether it's focal or not. And there are some laboratory tests that can help you rule out different conditions. But I don't want to stray away from the focus, which is HD. So how can we manage it? So it really takes a multidisciplinary approach. So it's not just a physician, it's also nurses, physiotherapists, speech and language therapists, dietitians. So these patients lose a lot of weight and can have trouble swallowing. So nutrition is key to make sure the patients are well. And we really want to optimize quality of life and be prepared to respond to changing needs. And then let's look at pharmacological, non-pharmacological interventions. So for chorea, we have VMAT2 inhibitors, such as tetrabenazine and deutrabenazine. So tetrabenazine helps with chorea, but can lead to sleep problems and particularly depression and anxiety. Deutrabenazine is a modified version that has a longer half-life and possibly less depression and somnolence. We can also use for chorea neuroleptics, such as olanzapine, but they naturally have sedation and weight gain, which in this case isn't necessarily a bad thing. So in terms of the abnormal gaits, poor balance, and frequent falls, physiotherapy can help. The psychiatric symptoms, there isn't a lot of literature to help decide on the best treatment for HD patients, but we can treat the symptoms according to the best practices for each symptom. So for instance, for depression, anxiety, OCD, and irritability, we can give antidepressants such as SSRIs and also mirtazapine and venlafaxine. And for the aggression and psychosis, we can give neuroleptics and cognitive behavioral therapy, even though after cognitive impairments, it becomes more difficult. And for apathy, that's a very frequent symptom. There isn't a lot of evidence, but some people have tried amphetamines and amantadine, but there really isn't evidence. For the cognitive symptoms, it's very disappointing. So anticholinesterase inhibitors and citalopram don't seem to have a very convincing results. Some coping strategies can help, such as changes at the work setting, a quieter environments, and less multitasking. Okay, so new therapies in development. There's a lot of research that's being translated now to clinical trials. Some is looking at the source of the disease in the DNA using gene editing tools such as zinc fingers and CRISPR-Cas9, and to try and get out the mutated gene and change it for a normal allele. That's still in development. Closer to the patients are the RNA therapies, so ASOs and RNAi. They are a bit different. So ASOs can act as the pre-mRNA stage and leads to mRNA destruction through different machinery from RNAi. So there are ASOs already being developed which lower HTT as a whole, and they are delivered through intrathecal injections on a monthly basis. And there are some therapies which are allele specific, so they only silence the mutated allele. So, for instance, if the allele the mutated allele comes only from the father, you can develop an ASO specific for that allele so as to preserve the good allele. And that's important because The HTT gene has functions, and it's important for brain development. It's actually embryonically lethal if you switch it off. So usually this would be therapies for adults. Okay, and so there are also other therapies being developed that's focused on neuroinflammation and proteostasis and many other mechanisms. So take-home messages. HD can affect patients of all ages, as you have seen. The symptoms are not just chorea, they're also cognitive and behavioral. It's first hyperkinetic and then hypokinetic. And predictive and diagnostic testing are different things. You wouldn't test a child that doesn't have symptoms. That child should have the chance to choose for herself at a later age. Okay, and then there's an evolving understanding of pathology. And it's interesting that these mechanisms seem to be preserved across trinucleotide repeat disorders. Okay, also don't forget that there are other causes of chorea, and that's you need to treat the patient as a whole, and there is hope for new treatments. I would like to thank everyone for your attention, and in particular thank the program for having had me for this 6 weeks. I really enjoyed my time here. Thank you.